Glaucoma is the leading cause of irreversible blindness worldwide. One of the critical aims of treatment is to find out progression early. Progression can be best identified by either visual fields or by analyzing the structural deterioration via optical coherence tomography. Visual fields are therefore necessary for the diagnosis and to assess progression of the disease. Evaluation of visual fields was done more than 2000 years ago. It was first done by Hippocrates in late 5th century BC. First instance of recording recognition of extramacular visual fields was done by Galen in 175 AD. Measurement of visual field extent was performed by Thomas Young in early 1800s, where he reported size of normal human visual field is 60 degrees superiorly, 70 degrees inferiorly, 60 degrees nasally and 90 degrees temporally, which was later refined by Purkinje. Von Graffi had a major contribution for introduction of perimetry in ophthalmology and visual field testing. Jerome was the one who has brought the tangent screen for quantitative evaluation of visual fields. Harry Tracquair had made a lot of work on the utility of the tangent screen. He had described the visual fields as an island of vision surrounded by a sea of darkness. But the tangent screen could only evaluate the central 30 degree. To overcome this problem came the Lister's perimeter or the arc perimeter. It is a metallic semicircular arc graded with degrees and white dot in center for fixation. But it was unable to provide consistent background and it measures in 45, 90, 135 and 180 degrees only. Next came the Goldman perimeter. He used a hemispheric bowl with background illumination and moving optical projection system. It superimposes bright stimuli on black background. All these perimeters have a moving target and are called the kinetic perimeters. In kinetic perimetry, a stimulus is moved from a non-seeing subthreshold area to a seeing suprathreshold area, and the location where the object is first seen is recorded. Pitfalls of kinetic perimetry: lack of automation provided by most instruments, lack of comparison of results, the need for experienced technician, potential for missing subtle scotomas, and length of time required to perform the test. A majority of these problems are overcome by the standard automated perimetry where the object position is static. The two commonly used ones are the octopus and Humphrey field analyzer. Here, stationary stimuli are presented at defined points in the visual field. The stimulus intensity can be altered, which helps to find out the sensitivity of each point that is tested and its threshold. They have a normative database for comparison with age-matched controls and it gives the average deviation from normal. Over the past 50 years, since its inception, various incremental innovations have been developed. Full threshold strategy, where bracketing technique is performed at every point, which is time consuming, followed by the fastback strategy with a single reversal using an increment of 3 decibels, to latest Theta strategy. The latest update is that of Theta faster, where the testing time is that of 3 minutes. Though the standard automated perimeters are the ideal ones to assess progression, they are not without disadvantages. The perimeters are bulky, cannot be mobilized easily and therefore could be done in office settings only. Some patients might be trigger happy, resulting in high false positives and white scotoma. Inattention, fatigue, boredom may result in high false negatives and a clover leaf pattern of visual field defect. Patients may not be able to understand the testing method.
Oh my God, what does that thing do?
That's an eye removal machine.
All right, I'm out.
I'm kidding.
They are also required to maintain position for the duration of the test, which might not be possible for elderly or disabled. Moreover, it is time-consuming, requires a learning curve and should be done by trained staff for optimal reports. To address these problems, small portable visual field testing instruments are being developed based on virtual reality. Various reports have suggested that these virtual reality-based perimeters have been shown to be equally effective in diagnosing glaucoma. These perimeters are compact, lightweight, does not require specific posturing and 5 times cheaper than the standard automated perimeter. The compactness allows it to be used in screening camps and vision centers, thereby improving the yield of glaucoma diagnosis. Major limitations of portable devices are inability to control fixation and distance from eye to screen. The current developments address these disadvantages by employing adjustable fixation using gaze tracker. This compensates for the fixation deviations. That is, no matter where the patient is looking, stimulus can be shown related to fixation at that moment. The parameters based on virtual reality of course needs validation and development of a normative database. But the future looks bright for virtual reality-based field testing. Thank you.